नमस्कार सर।
वेलकम डॉक्टर गिरीश सर भी आ गए, डॉक्टर कनव भी आ गए, सब आ गए हैं।
Good morning, respected faculty delegates. I request Dr. Dinesh to please start.
Yes, thank you, sir. Thank you. So, good morning, everyone, and I welcome you on the behalf of IIP Delhi office. This eNephro masterclass session, and today's topic is bedwetting in children. We all know this is a very common problem among our OPD childrens, and many time day wetting, night wetting, and many issues with them. So today we are having one esteemed faculty from Gangaram Hospital, Dr. KANAV ANAND. I think he doesn't need any introduction, and everybody knows him in the country. And with us, Dr. Girish Bhatt is also with us as an expert. And the chairperson for this session is Dr. Piyush Jain, who is the head of the department of Hindu Rao Hospital. So, and for this course, I must congratulate again and again Dr. Neha Bandari. And this going is wonderful course, and it's increasing our knowledge in nephrology and updating ourselves. So there are many news from IIP Delhi offices also. We are having next month the PCNI Pediatric Conference of North India 2026 at Lee Meridian on 2021 June. Those who have not yet registered, please register for the conference. And one nephrology workshop is also on 7th. So those who want to join the workshop, they are also welcome for the workshop. Now I would like to invite Dr. Ajay Gupta sir to say a welcome address. सर आवाज नहीं आ रही आपको.
Thank you, Dr. Dinesh. I once again welcome all respected faculty and dear delegates who had been joining on Sunday mornings. With us, we have today Dr. Piyush Jain, who is head of the department at Hindu Rao Hospital and Medical College. I request him to please say a few words.
Thank you, Dr. Ajay. Thank you, Dr. Dinesh Goyal, for inviting me to chair this session. Dr. Bandari is with us, Dr. Girish, Dr. KANAV ANAND, they are the experts in nephrology, and no words are enough in their praise as the work they are doing in this field. So today we have a session on bedwetting in children. Bedwetting, is quite common. In our daily practice, we keep on having some children in which the mothers and parents complain the child is wetting the bed at night. But over the years, the diagnosis, the method of diagnosis, as well as the treatment of bedwetting has been, we'll say, changing or even improving. And right now, there are many medications which can be followed and the causes can be ascertained, and the bedwetting can easily be controlled. To talk more about this, we have the expert, Dr. KANAV ANAND, who will go us through this session for the next 1 hour. Dr. KANAV ANAND.
Thank you, Dr. Piyush. And I request Dr. Neha Bandari, coordinator for nephrology session, to introduce Dr. Girish Bhatt and Dr. Kanav.
Thank you, sir. First of all, I would like to thank IIP Delhi, Dr. Ajay sir and Dr. Dinesh. Sir, it's so much of dedication, and we have a lot of our nephrology delegates who are waiting for this wonderful session, because it's such a common problem that we rarely see. Almost every week we have 1 or 2 bedwetting patients with us. So we'll not waste more time, and I would first of all like to welcome our expert, Dr. Girish Bhatt. Sir is a professor in Division of Pediatrics in All India Institute of Medical Sciences, Bhopal, India. He's a very, very renowned faculty in pediatric nephrology. He has authored almost more than 100 peer-reviewed publications and book chapters. Plus, he has also started in AIMS, Bhopal, DN Pediatric Nephrology. So welcome, sir. I'm sure it will be an enriching experience to have you with us as an expert. Then I would like to welcome Dr. KANAV ANAND. He's the speaker for today. We all know him very well, and I am really feeling honored today to introduce him, because he is my mentor from Gangaram Hospital. Sir is currently chairman in pediatric nephrology division and renal transplant at Gangaram Hospital. He has started the fellowship programs in Gangaram Hospital. He is a recipient of various awards. He has written presented more than 100 oral papers, posters, and I think he's one of the pioneers in pediatric nephrology. And as Dr. Dinesh said, that he doesn't need any introduction. Over to you, Kanav sir. We can start the session.
I'll just share my slides once.
Screen is visible. Please click on continue to share.
No, it's mother screen is available. 1 second. I'll just share it once more.
Yeah, sure. Yes, now it's okay.
Fine, not fine. So at the outset, let me thank IAP Delhi for inviting me for this lecture on approach to bedwetting in children. And special thanks to Dr. Neha Bhandari, who's coordinating the whole program. And special mention to our chairperson, the expert, and the president and the secretary. So without wasting much time, so I'll be talking about approach to bedwetting in children. And what we will cover over this next 30 to 35 minutes will be the definition and terminology, the burden and the impact of bedwetting in children, a brief overview of the lower urinary tract physiology and bladder maturation, the pathophysiology of bedwetting in children, the various comorbidities, how to evaluate such children, investigation whether needed or not needed, and when to upscale the investigation, and the various treatment modalities, whether it's urotherapy, the alarms, the desmopressin, the drugs, how to label a child as having a refractory enuresis, and a stepwise algorithmic approach which you can use in your day-to-day practice. So coming to the current terminologies, initially the wordings were used as the terminology was nocturnal enuresis, means nighttime bedwetting. So over a period of time, it has the night or the nocturnal word has been removed and enuresis has been coined. The reason being, a lot of confusion used to occur. That is it, if the child wets only during the night time, do we label this child as having bedwetting? Or if he sleeps during the night or during the daytime and he wets at the afternoon time also, does that also get incorporated in the term of enuresis or not? So whether the child is in the daytime or nighttime, but he wets the bed during sleep, it is termed as enuresis. So according to the International Children's Continence Society, so what is enuresis? It's intermittent urinary incontinence during sleep in a child whose age is more than or equal to 5 years. The practical threshold is more than one time per month for at least 3 months is when we label this child as having bedwetting. We can divide it into two parts, either a primary or a secondary enuresis. Primary enuresis means the child has never attained continence during the sleep time. And so these children are labeled as primary enuresis. And secondary enuresis is when the child uh, has attained continence for at least 6 months at a stretch during the nighttime. So this is very important for us to know. Reason being, although the treatment strategies may be same, but the causative uh, things may be different. Like in secondary enuresis, we may think about maybe the stressors that have come in, a new, maybe a sexual abuse may be there, constipation would have come in, or the child would have, over a period of developed diabetes mellitus. So, in case there is a break period of 6 months at a stretch where the patient has attained this thing, continence during the night time, and now he starts having bedwetting again, that is labeled as secondary enuresis. Then we can also divide it as monosymptomatic versus non-monosymptomatic. Monosymptomatic means the child is only having bedwetting as the problem. That is, he passes urine during the sleep. But in non-mono symptomatic enuresis, he also has daytime urinary symptoms, whether it is in the form of, you can say, urgency or hesitancy or increased frequency of urination during the daytime. So we need to first differentiate between the two, primary, secondary, monosymptomatic, non-monosymptomatic, because your line of management, the reasons for it are totally different. Now, coming to the burden, prevalence, and the impact, around 15% of the children at the age of 5 years wet the bed. So the incidence is almost, the prevalence is almost 15%. The males have 2 times higher prevalence as compared to the female counterparts. And there's a 44 to 77% risk of bedwetting if either of the parents used to wet during their uh, childhood. What is the impact of bedwetting and why we need to treat it? Because it lowers the child's self-esteem, not about the child alone, but it also causes a lot of social issues with the parents as well. The it can cause disrupted sleep and attention, social restriction both for parents and the children for sleepovers, camps, and successful treatment not only improves the working memory but also the quality of life for the child. Now, coming to the physiology behind the lower urinary tract uh, maturation. So, the lower urinary tract is controlled by the brain, the cortex, which has a frontal lobe, which sends signals, which actually helps in controlling the maturation and it helps in bladder relaxation. Then we have the pontine maturation center, which helps in initiating the act of maturation by contracting the bladder. Then we have the spinal cord, where we have the autonomic nervous system, both sympathetic and parasympathetic, and bladder control. And we have the pudendal nerves, which has a voluntary control over the maturation. So, what do you need for a normal lower urinary tract to function? One is the storage function. So, it is filling of the bladder in a continent manner, and the urine needs to be stored at less than 15 centimeters of water. Because if the pressure is high, definitely you'll leak and it'll have detrimental effects on the kidney. The sympathetic nervous system, comprising of T11 to L2, relaxes the detrusor muscle, contracts the internal sphincter, and it helps in storage of the urine. So for the delegates who have joined in, how to remember is for storage, it is sympathetic, S for S. And you have the pudendal nerve, which has a voluntary external, which controls the voluntary external sphincter and lets you go to the toilet at the right time and initiate the act of maturation or the helping you with the storage of the urine. Now, for emptying, it should be voluntary, it should be complete, and it should be under low pressures. That is less than 40 centimeters of water. The parasympathetic nervous system actually helps in emptying, and it contracts the detrusor muscle and relaxes the internal sphincter. So, how to remember? Parasympathetic starts with P, and P is for peeing or emptying of the bladder. The pontine center coordinates the detrusor sphincter synergy and helps in initiating the act of maturation. So coming to the normal maturation cycle, so by 12 to 18 months of age, you get the awareness of bladder filling. By 2 years, you get the daytime bowel control. By 2.5 years, you get a daytime urine control. By 3 to 4 years, you get the nighttime urine control. And we label the child as having bedwetting only if he has not attained the nighttime urine control by even 5 years of age. So 1 year is that leverage period that we give to these children. Now, the expected bladder capacity for the age, how do we calculate that? It's age plus 1 in years into 30 ml. So if it's a 10-year-old child, it's 10 plus 1, that is 11 into 30, that is around 330 ml. And this capping is till 12 years of age, by where the bladder attains the normal adult size, that is almost around 400 ml. Now, we label this child as having a small bladder capacity child if the maximum void volume is less than 65% of the expected bladder capacity. So that means it's a small bladder, which may improve with time. If it's a small bladder and the child grows, the bladder also grows. Or it may be a temporary small bladder or reduced functional bladder capacity. If it's a transiently small, it has been made transiently small by the, you can say, the fecolates which are present in the rectum, and it is compressing the bladder and not letting it expand. Now, we label the child as having nocturnal polyuria if the nighttime urine production is more than 130% of the expected bladder capacity. So definitely this child having nocturnal polyuria will leak because of the increased volume of urine. This can happen because of increased drinking of liquids during the nighttime or because of decreased ADH release. So this helps you in deciding what kind of therapy should I offer to the child. So if it's nocturnal polyuria, maybe desmopressin is going to help you, or whether it's a small bladder capacity, the alarms are going to help you. Now, coming understanding the pathophysiology behind bedwetting. So, one is nocturnal polyuria, that is high urine output at night, more than 130% of the bladder capacity. It can occur because of increased evening liquid intake or increased solute intake, whether in the form of salts or in the form of proteins or in the form of high sugar intake, and because of the blunted ABP response. Then you have an arousal problem where the child does not get up with a full bladder. The brain's, well, the bladder is getting filled up. The nerves are being triggered off, but the brain does not get aroused and the child does not wake up. And then you have local bladder problems, whether it is reduced functional capacity or a small bladder or a bladder bowel dysfunction. So all these can contribute to enuresis. So what, as doctors, we are supposed to find out is what led to enuresis in this child. One child may be having one problem or maybe having multiple problems, and we need to focus on all the problems together to get an adequate response. Along with that, we have modifiers, whether it's in the form of genetics, if the parents had bedwetting in the past, bladder bowel dysfunction or constipation, that needs to be treated, sleep disorders like maybe adenoid hypertrophy or sleep apneas, that also needs to be treated. The psychological stressors may be there in case there is some stressor in the family, that needs to be taken care of. And in case the child has some ADHD, that also needs to be tackled. So unless you manage the whole scenario in a holistic manner, you may not get adequate response. Now, talking about genetics, so in case there is no family history, the risk, the prevalence may be around 15% of bedwetting. If one of the parents had bedwetting in the childhood, it's 44%. And if both the parents had bedwetting in the childhood, the risk is almost 77%. There's an autosomal dominant inheritance with variable penetrance. And usually, does it actually matter to take this history or not? So, one, in case it is there, so you can tell the parent that yes, it's a genetic problem. Ask them when did they actually stop wetting, and approximately you can just counsel them that this child may also take a similar time to get better. Two, since it's a family history related problem, hence you should not blame the child for it. It's the genes which needs to be blamed, and it's not just the child's behavior. Thirdly, it helps you in counseling as well and to anchor the expectations of the family. And if you ask in terms of therapy, it does not matter whether the child they had family histories of bedwetting or not. Your line of management, your therapy is going to be same. So what it actually helps is in counseling of the parents that okay, don't take stress and let's wait and treat the child. And most probably the child, as you got better, the child also will get better. Now coming to sleep and bedwetting. So most of the parents feel the child is a deep sleeper and he does not get up when the bladder is full. And then they start, you can say, the punishing the child that you should get up. So, but you need to tell the parents that it's during the sleep time that the bedwetting is occurring, and the child is actually not aware of what is happening. So, if you keep on uh, the thing, scolding the child, so it is going to increase the stress in the child, and it's going to increase the bedwetting rather than decreasing it off. So these children have high threshold to bladder signals. The failure to wake up despite a full contracting bladder. The polysomnography may reveal longer sleep latency and more arousal from a non-REM sleep. They have lower sleep efficiency. And in case the child has disordered breathing at nighttime because of snoring, mouth breathing, adenoid tonsillar hypertrophy, that also needs to be treated. So in case the child is a mouth breather, so his mouth gets dried up during the sleep. He drinks a lot of water during the evening or the night time. And as a result of that, he has nocturnal polyuria and starts wetting. So you need to treat your comorbidities as well. And some children may need adenotonsillectomy, but only in selected cases where obstructive sleep apnea is documented. And studies have shown that if you just treat the obstructive sleep apnea, 30% of the children will outgrow the disorder of bedwetting without you actively doing anything. And then they need to know that deep sleep is the biology and not just the laziness of the kid. A quick OSS screen should be done in your OPDs. Loud habitual snoring, mouth breathing at nighttime, witnessed apnea, gasping, restless sleep, sweating during the nighttime, daytime sleepiness, that is somnolence during the day, poor school performance, and adenotonsillar enlargement on examination, either by clinical or from the X-ray. So these things need to be actually treated off. Either you can treat it as a pediatrician or you need to take ENT help. So unless you treat these comorbidities, you may not get an adequate response. So this is a small this is a sleep study of one of my patients who's a 16-year-old child, and parents were actually waiting till 10 to 11 years, thinking that the child is going to get better with time, but then she did not. Then she started having menses, because of which there was increased stress in the family, both in the child and the parents. That's high time this child is not getting better. When the parent came, he said that the child is a deep sleeper. She does not get up. Now she has gone 16-year-old. She has matured. Menses have started on. Still, she does not get up. So there's problem with this kid. So when we did the sleep study, what we found out that there's a restless sleep. Frequent positional changes indicated restless leg movements. Patient had loud, intermittent snoring in the supine position, suggestive of upper airway resistance with restless leg syndrome. So this was because of the persistent tonsils and the adenoids, which need to be managed in this child, and as a result of which the bedwetting was occurring. According to the parent, she said the child is a deep sleeper, but in the sleep stages, what we found out was almost three-fourths of a sleep was light sleep, and deep sleep accounted only 22%. So this is contradictory to what the mother was thinking. And mistakenly, 82% of the parents believe that deep sleep or laziness are the major causes of the child's bedwetting, and it may be the other way around. So children with monosymptomatic emesis have a longer time to fall asleep and have poor quality of sleep than their counterparts. Now, coming to bladder bowel dysfunction as a comorbidity. So, remember, you need to treat it to get your bedwetting aligned up. And also, if you do not treat it well in time, it will also diminish the response to your drugs. Example, if I'm giving a child desmopressin to decrease his nocturnal polyuria. So, in case the bladder is small, how will the desmopressin help in this child? So, you need to treat the constipation. So, in case, as you can see in this cartoon, there's stool which is filled up in the rectum. It is so much filled up that it is compressing the bladder. So, if it compresses from top, that is the detrusor, the bladder capacity becomes small, the functional bladder capacity. And as a result of it, in the daytime, the child may have overactive bladder, urge incontinence, urgency, and at night times, you'll have multiple episodes of bedwetting during that night sleep. So that is how you get that hint, whether it's one time during the whole sleep or it's multiple time during the whole sleep. Secondly, if you have a fecolith sitting at the bladder neck, so this will decrease the, you can say the emptying of the bladder. As a result, there may be significant post-void residues. The child feels that I have passed my urine, comes back, sleeps off, but then there's a significant amount of urine still in the bladder, which he leaks off at night. So that's why you need to manage both the stools as well as the bladder to get an adequate response. So the pelvic lower unit tract and the lower GI shares common embryology and innervation. So problems with elimination of one leads to problems of elimination of the other. So you need to find out whether the child is having constipated or his child is constipated or not. Some parents may directly say that yes, my child is constipated in by virtue of stools passing less than 3 times in a week, hard painful stools, large caliber stools, or soiling. But at times, the parents may straight away say, no, my child is not constipated. But if he gives you symptoms suggestive of encoparesis, the child says, I'm unable to completely evacuate my bowel, then definitely it needs to be evaluated, because the child is giving you hints that the child may be constipated or maybe inadequate evacuation of the bowel is occurring. And that too can also lead to a lot of troubles. So you can show the Bristol stool chart to the parents or the child and ask them, what kind of stool does the child pass? So if the child is passing large, chunky stools, definitely will cause compression on the bladder. Now, coming to secondary enuresis, as we told, the secondary enuresis means the child is uh, has bowel control, bladder control for at least 6 months at a stretch at the night time. But now again, he started wetting. So, what are we supposed to see? The psychosocial issues, the bereavement in the family, parental separation, a new sibling, bullying, and maybe sexual or physical abuse also needs to be checked. So, that you can check either by talking to the parents, or maybe the hints may be there while evaluating, or you can say examining the kid by injury marks at the genitals or perianal area. So new constipation, if it comes in, definitely will cause aneurysms, recurrent UTIs, or a new polyuria or a polydipsia-like scenario where a diabetes mellitus, diabetes insipidus, or a hypercalciuria, hyperoxaluria is coming. Now the approach should be find out what are the causes of this aneurysms and treat them accordingly. Behavioral counseling may be required at times. Such children may require urine dipstick or just a urine analysis just to see whether there is proteinuria, pyuria, or crystalluria. Screen for thirst or polyuria. And basically, if the child has increased nighttime thirst, then maybe there is a maybe an over this thing, the uh, uh, you can say problem with your adenoids which may have come in. That's when nighttime thirst has increased. If the child is thirsty throughout the day, then look in for features of diabetes mellitus or diabetes insipidus. Look for the growth of the child, check the blood pressures, which tell you some hints towards kidney involvement, either in the form of renal tubular acidosis or the diabetes, or maybe a you can say an early chronic kidney disease. Address the triggers before you actually start addressing the enuresis, and mental health and safeguarding referral, if abuse is suspected, should be done at the right time. Now, coming to how do you evaluate such children? So, first is history, history, history. So, most important is history. So, it's wet nights. How many times the child is wetting? In one night, he wets multiple times, single time. What's the age of the child? Any lower unit tract symptoms need to be checked off for. Do ask them one by one each of the lower unit tract symptoms rather than just blanketly asking, is the child okay during the daytime or not? So, you can ask them about urgency, urge incontinence, frequency. Everything needs to be asked one by one. The fluid intake during the daytime, nighttime, the quality of fluid intake, obstructive sleep apnea, family history, psychosocial scenarios, and the behavioral pattern. On examination, look for the growth, the BP. Examine the abdomen for any fecolates. The perineum needs to be seen for any anal fissures or a patulous in suggestive of a neurogenic bladder-like scenario. The spine needs to be seen for tuft of hair or a spinal dysraphism. The neurologically, the child needs to be evaluated, and the ENT needs to be seen. And whether the child is having any other comorbidity like ADHD or autism also needs to be evaluated. Now we do a 48 to 72-hour bladder bowel diary, which includes your stool charting, your urine charting, and the whatever liquid the child is taking. You have validated LUTS score systems also available, which you can use if you have a busy OPD where somebody else or your nurse can do the screening and help you out with the detailings. Now, then targeted tests, urine dipsticks, and detailed testings like ultrasound, MCUs should be done only if special red flag signs are there. Otherwise, 90% of your job is done with history taking and your bladder diary. Now, coming to active screening for the monosymptomatic aneurysms, just to differentiate them from non-monosymptomatic aneurysms, because if you do not pick up these non-monosymptomatic aneurysms and you start treating them just as mono, most of the times you may find a partial response but not a complete response. And do remember, these children who are monosymptomatic aneurysms children at starting, in between may develop features of non-mono also. So you have to keep on reanalyzing, revisiting the bladder diary and seeing whether the child is still behaving as a monosymptomatic or he has developed some features of non-monosymptomatic. So in that, what we do is we ask for the frequency. If it is less than 4 times or 7 times voids per day, this is taken as low frequency or high frequency. If the child has urgency, sudden need to go to the toilet, urge incontinence, daytime leaks, it falls under the category of urgency. If the child is having holding maneuvers in the form of Vincent's curtsy sign as seen in this photograph, the child is crossing her legs just to increase the pelvic floor muscle tone so that he can hold the urine, needs to be checked. The voiding stream needs to be checked. Either you can physically do it in the toilet or ask the parents to make multiple videos of the urinary stream, and you can just evaluate during your OPD hours. Whether the child is having hesitancy, means he has a problem starting his urination, straining while maturating, intermittent stream or a weak stream also needs to be checked. After voiding, you need to ask them about post-voiding dribble, suggestive of significant PVRs, and the sense of incomplete emptying in the child. Ask them about recurrent UTIs in the past or history of stones in the past. And in case it is there, then they also need to be well evaluated. Now, coming to the bladder bowel diary, which is the single most useful investigation in these children, it gives you the records of the time and the volume of each void during the day and the night, the leak episodes with time, bedtime and the wake up time, the fluid intake, the volume, the type, and the timings, the stool frequency, and the Bristol chart can be used for noting down what kinds of stools did the child pass, and along with that, also mention the quantity of stools the child passed, the urgency, and the holding episodes. So this is a small example of the bladder diary which we have made for one of our patients who is 10-year-old. And one side he writes the timings along with the liquids that he has drunk. and what time, what ml. Then there is a stool chart where he has written small quantity peanut-like, pellet-like stools, which he has passed. That means it's a small quantity and hard stools. Then here we have the timing, and along with that, we have the urine volumes that he has passed. So by 10:30 p.m., this child has slept off. And during this time, when you're making this bladder diary, since the history was the child wets twice during the night time, I asked the parent to wake up the child twice so that I can get the exact volume of urine that was there. So the child was woken up at 2 a.m., it was 200 ml, 3 a.m., it was 150 ml. And finally, this child wakes up in the morning at 7:30 a.m., it was 200 ml. So this is what needs to be noted. And in case there is a leakage episode which the parent could not note down, the volume could not be noted down, so that needs also to be incorporated. Sleep time, night wake up time was written, and the total intake of liquid and the total output of urine was also noted. On the right hand side, we have this small calendar like diary where on the days the child has wetted, the days were marked. So that tells you the frequency of bedwetting the child is having. So how do we interpret this diary? So the urine frequency, what was noted here was 11 times, which is much higher than the child. It should be in the range of 4 to 7. The expected bladder capacity is age plus 1 into 30. So that is 11 into 30, that is 330 ml. The max void volume noted was 200 ml, which is less than 65% of the bladder capacity, suggesting it's a small bladder capacity. The minimum volume was just 25 ml. And that is the reason why the child was passing more number times the urine. Total urine volume was 1475 ml, which falls in the normal range of the child is not having polyuria. The urine produced during the sleep time was 550 ml. Sleep time means how do you calculate the nighttime urine volume? Is the nighttime volume plus the morning first void of the next day. Total incorporates the nighttime volume, that is 550 ml, suggestive of nocturnal polyuria as it's more than 130% of the expected bladder capacity. Then we have a look at the nighttime liquid intake, which he took 2 hours prior to sleeping at night, which was 400 ml. So if he's drinking 400 ml prior to sleeping at night, definitely the urine volume is going to increase. Then the bedwetting was 7 days out of 2 weeks. So that tells you my frequency of bedwetting. So how does it help you in planning the treatment for this child? One, cut down the liquid intake at bedtime so that the nighttime volume comes down. If it still does not come down, then this child may benefit from desmopressin. Two, constipation needs to be treated well. Otherwise, my bladder is not going to expand off. Three, the frequency is high and his child is passing small volume urine. So in case you have treated your constipation and the bladder expands off and the volume becomes better, that is the end of the story. In case still it does not get better, then maybe I can take help of, you can say anticholinergics during the daytime, and at time you can use alarms during the night time for your bedwetting. So that is how you plan the strategy for these children. And we keep revisiting this bladder diary, maybe on a regular manner, just to see whether the child is compliant or not, and whether my treatment is working or not, and the net effect, whether the bedwetting is coming down or not. So coming to the investigations, the most important is history, examination, and the bladder diary for 48 to 72 hours. So this is baseline mandatory for all children who come with bedwetting. A urine analysis or dipstick can be done. So these two forms the basis of majority of your bedwetting evaluations. Ultrasound, KUB, post-void residual urine only in selected patients, not all. Renal function tests, MCUG, MRI spine, again in selected patients, and very rarely urodynamics and video MCUG, only when the child is refractory to all of them, but should be done by a specialist only. So majority do well with your history, examination, bladder diary, and maximum a urine analysis. Now, the red flag signs which you should be aware, which tells you that this child needs specialist referral, as well as this child may need other forms of investigations. So one, if the child has daytime lower urinary tract symptoms persisting even after proper urotherapy. You have told them the behavioral modification, everything has been told, still LUTS is not taken care of. Recurrent or febrile UTIs in the past, abnormal urine analysis where you find glucose, you find proteins, you find pyuria, excessive thirst or polyuria, along with weight loss, poor growth or failure to thrive, hypertension, abnormal neurological examination, abnormal spine examination, abnormal perineal examination. Continuous dribbling of urine, which can be either because of poor control of poor detrusor contractions or even say relaxations, or because of you maybe an ectopic ureter, which is causing continuous dribbling. And if you have structural concerns, the ultrasound, whenever done in the past, was showing, you can say, thickened bladder or a bladder diverticulum, suggestive that there may be an associated bladder structural problem. Severe constipation, encoparesis, which is refractory to treatment, suspected obstructive sleep apnea, where a ENT referral is required, significant development of behavioral disorders like autism, ADHD, failed alarm, failed desmopressin, and the child is refractory to treatment, does need referral. Now, as a primary care physician or a pediatrician, so you can manage majority of your patients almost to the tune of 80%. And what you need to see is if the age is more than 5 years, intermittent wetting only during sleep time, primary monosymptomatic aneurysm, no daytime LUTS, normal growth, normal blood pressure, normal physical, abnormal perineal, spinal, and neurological examination, a normal urine analysis, and no red flag signs. So these patients can be easily managed at a peripheral level without any active intervention or you can say consultation by a specialist. But in case it is not following this track, definitely these needs a referral. Now coming to the first line management of urotherapy. So there the foremost thing is education, education, education. Mainly you have to allay the anxiety of the parent as well as the child and tell them what caused bedwetting in the child and what are you offering to this patient so that they have a, you can say, they know what is my line of management. Do tell them approximately how much time does the child take to get better. Otherwise, they feel that, okay, I've shown you today, and by next 1 month, my bedwetting should have been gone. So you have to tell them, okay, this is my disease process. This is what led to the problem. And this thing to get better may be taking a weeks, maybe months or years. So tell them that's not a child's fault. Enuresis is a biology, not laziness or defiance. No punishment should be given as it decreases the self-esteem and maybe the depression in the child and will increase the chances of bedwetting. Explain them how bedwetting, what is a normal physiology, what all can lead to bedwetting. Give them realistic expectations. Reward the efforts, not the dry nights. So as we have the, you can say the star charts are there. So that can be given. But then normally in the previous, you can say 15, 20 years back, it used to be said that if the child does not wet the bed, give them a red star. And if the child wets the bed, give them a black star. So remember, if the child is trying to do and trying to follow what you have told, do give them a red star because the more red star you give, it helps you in the motivational scenario and increases the compliance towards the controllable behavior. But if you start giving them a lot of black stars, it becomes a more of a negative affair rather than a positive affair. Then have a shared decision. Tell them your management depends upon how much as a parent, you are part of the management, how much the child follows whatever has been told, and how much the doctor does it. So it's a shared care between all the three, and that is what results in adequate outcomes. Then next question that is usually asked, should I wait or should I treat this child? So you can wait and watch if the child is less than 5 years old, because at times in our OPDs, 4-year-old patient is also brought in saying that child wets, is still wearing diapers. So do not treat them, but do tell them what all urotherapy options do you have so that the parent can start training this kid well in advance. Child or the family is not distressed, definitely you can wait on. There's no social functioning or self-esteem impact. And use urotherapy, reassurance, and ask them to come back on a 6 monthly basis and see whether the bedwetting is improving or not. But on the other side, you can offer them active treatment if the child is bothered, embarrassed, or socially restricted. So in youngsters aged 8 to 18, bedwetting was seen as the third most traumatic event after divorce and parental fighting. So do not underestimate the social issues because of bedwetting. The self-esteem and school performance is getting affected. The family is ready for starting therapy, and usually the child should be more than 6 to 7 years of age. Less than that, less likely they are going to improve with your therapies. And if the sleepovers, school trips, camps have been planned up, then definitely you can help them out for a couple of days to tide over that period. Now, what is standard urotherapy? Now, first, you need to distribute the fluid intake 40% in the morning, 40% in the afternoon, 20% in the evening, and 2 hours prior to sleeping at night, you should stop the liquid intake. So this needs to be told off because what happens is at time we just say, okay, so before 2 hours prior to sleeping at night, just stop the liquid intake without telling them that you have to increase your liquid intake during the daytime. If you do not do that, the child will actually get dehydrated and increase chances of constipation, and this will again trouble your management of bedwetting. You have to tell them that void every 2 to 3 hourly, max 4 hourly, so that the child gets the habit of passing urine on a timely manner. Because what happens is in the school time, the child is holding urine for almost 8 to 12 hours. And at night times, the bladder starts passing more urine just because you've held it too often. So that needs to be tackled off. Sensible hydration, proper toilet training should be done, both for urine as for stools. The child has to sit on a feet supported manner, and you have to open your legs when you sleep. If you when you're sitting and passing urine, and do not cross your legs while you're passing urine or stools, because that you can say that tightens up the sphincters. Treat constipation, lower urinary tract syndrome, and oral and obstructive sleep apnea if there. Caffeine, fizzy, carbonated drinks, salty diet, sugary diet should be avoided during the evening and the night time. And fluid restriction during the day should be told. Now, what options do we have as first line therapies? The alarm therapy as well as the desmopressin therapy. The alarm therapies are good long term cure. Families should be committed. If you find that the families are not committed, alarms may not help at all. The child should be capable of waking up and going and passing urine when the alarm rings off. The effect is usually seen in weeks to maybe around 3 months, and review the child every 4 to 6 weekly to find whether they respond to treatment or not, whether they're compliant with alarms or not. 60 to 70% of the child will get better with alarm therapy. Long Lower long-term relapse rate has been seen with alarm therapy, and it can be easily retreated with the use of alarms only. It is labor intensive. The whole family engagement is required because it keeps ringing. The child does not get up. The family is getting disturbed. So that also needs to be told. Average, we wait for 12 to 16 weeks before we see a response. And in case you have a 14 days of bedwetting free periods, alarms can be let off. Coming to desmopressin, nocturnal polyuria, children uh, can be given desmopressin. They should have normal bladder capacity. It gives them rapid control over the urine output at night. And for sleepovers and camps, it's the ideal drug. Usually, the response is seen within days. 30% will show a full response, 40% will show a partial response, and it's a higher, you can say the relapse rates are there, for which structured withdrawal of the drug is required rather than suddenly stopping it off once the parent says, my child is not wetting. So low day-to-day burden is there. You can say it's less labor intensive, but requires strict fluid restriction during the night time. Now coming to a few words on alarm therapy. So here you have a sensor which has been put up at the you can say the undergarment, which gets activated once the urine starts flowing and the alarm rings up. Either it can be in the form of a ringing alarm or a vibratory alarm. The family should be committed. Explanation of the mechanism and the timing of like when do the alarm actually start showing a response needs to be told them. So, so that is how an alarm should be started off. You have multiple alarms in the market right now. Okay, starting from like you can say, and the quality should be ensured because at times what we see in the market, maybe those alarms which are used in your uh, water tanks. So there the sensing capability is much lesser. So unless it gets totally wet or flooded with urine, then only it will ring. Whereas the high-end sensors maybe alarms may be there, which usually with may get sensed off even with a drop of urine. So consider a good quality of alarm. Then the electrode needs to be cleaned once it's got wet with the urine, because if there is the formation of salt layer over the electrode, definitely will not ring, and the parent may say the alarm is not working. In case there is an associated bladder bowel dysfunction, you need to manage that. In case in 2 to 4 weeks, or maybe around not 2 to 4, around 4 to 8 weeks, you do not find much response, you need to reassess whether the child is compliant or not, alarms are being put up or not, and you may even think of combining therapy with other drugs. And in case you have 14 consecutive dry nights, then you can think of stopping your alarm therapy. Now, coming to desmopressin or synthetic vasopressin analog, it can be either given in the form of a melt, 120 micrograms to start off. Again, remember, you start with 120, not 60 micrograms, or a tablet of zero point 0.2 milligram tablet. Again, remember, so you start with zero point 0.2, not zero point 0.1. Then you can titrate it every 2 to 4 weeks for your adequate response, and you can go from 120 to maximum 240 and zero point 0.2 to maximum 0.4 can be given 30 to 60 minutes prior to sleeping. 1 hour prior and 8 hours after, the fluid intake should be restricted. Hence, you have to ensure that during the you can say timing problem, like when the child is having some kind of illness or is sick and is not able to manage his liquid intakes, definitely on those days, avoid giving desmopressin. In case he's having, you can say, he's playing some sports during the evening time, especially in the hot summer evenings, and after which he drinks a lot of water. So such children should not be given desmopressin, otherwise of high chances of dilutional hyponatremia. And counsel them verbally as well as in writing that what all things need to be taken care when you're using desmopressin. Review on a 3 monthly or maybe a monthly basis, and then decide upon how do you want to withdraw. Suddenly, do not stop this drug. You can just taper it off either on a daily basis or an alternate day basis to get the best results and avoiding relapses. So melt is comparatively preferred as compared to tablet formulation because it does not require too much of water intake to take the melt and has the better bioavailability of 60% compared to tablet, which is 40%. Nasal desmopressin have actually not been recommended because of high hyponatremia risk. And at times the patient may feel that I've taken one spray, but it has leaked off, and hence let me take 1 or 2 sprays extra. So there the high chances of hyponatremia risk is there. So before calling it refractory enuresis, do check the basics. That is, was the child constipated or not? Whether the daytime low tract symptoms were recognized by you or not. Maybe initially the child was monosymptomatic and now is turned to be non-monosymptomatic. Whether the alarms was used regularly for 8 to 12 weeks with the correct technique before you label it as alarm refractory. Desmopressin was used at adequate dose with correct timing, fluid restriction or not. If the child is having any other comorbidities like obstructive sleep apnea, ADHD, psychosocial stressors, whether they were treated or not, and if monotherapy fails, whether you have tried uh, dual therapy or combination therapy like alarm with desmopressin or not. If you have done all that and still you find the child is refractory or has red flag signs, definitely these children need specialist workup. So what does the specialist do? He may start off with anticholinergics like oxybutynin, tolterodine, in case it's an overactive bladder pattern, but ensure that there is no significant post-void residue. If you start anticholinergics, then constipation, dry mouth, heat intolerance should be there, may be there. So that needs to be evaluated and treated well. So in case you have started anticholinergic and you have treated the constipation well, the constipation is going to actually increase off and decrease your chances of an adequate response. Media background can be given. Initially, the pediatric data was very limited. Now it's coming up. But you need to check the blood pressure and the post-void residues in such children if you're starting. Imipramine, which was an age-old drug for managing bedwetting, and still one of the favorite drugs with the psychiatrists who manage the children with bedwetting and stressors. But then remember, as a pediatrician, you need to look out for the cardiotoxicity. There may be rhythm abnormalities, overdose lethality, behavioral disorders like even suicidability can be there. So hence a baseline ECG should also be done when you're trying for imipramine. The imipramine in most of the guidelines have actually been taken off, but in some of the guidelines still says it can be used as a third line agent. Then you have options of TENS, that is transcutaneous tibial nerve stimulations, which helps in, you can say, children more with overactive bladder with bedwetting. But then it has of limited relevance into and is done by usually either a trained therapist or usually the physiotherapists. So finally, to end off, we need a 7-step approach in the office. First, confirm whether the child is actually having bedwetting or not. Child is more than 5 years old, intermittent wetting during the sleep, daytime symptoms are there or not. Classify as monosymptomatic, non-monosymptomatic, primary or secondary. Look out for red flag signs in the form of daytime low tract symptoms, UTIs, abnormal urine analysis, polyuria, growth issues, blood pressures, neuropsychiatric involvements, and obstructive sleep apnea. Investigate in the form of only urine analysis and maintain the bladder diary. Detailed investigation may be required only if the child has red flag signs. Educate the parents, reassure them no punishment. Urotherapy should be initiated for all patients. Treat constipation if there and other comorbidities. Active therapy in the form of alarm and desmopressin by the phenotype and family choice can be discussed and given them. And children who are refractory, combination therapies may be tried and referred to a pediatric nephrologist or a urologist. So the key clinical messages after this talk will be bedwetting is common, distressing, and treatable. engage when the child is or the family is getting bothered. So do not sit over it and okay, tell them, counsel them, yes, you're going to get better with age, especially if your child is bothered. Classify them as different primary, secondary, mono, non-monosymptomatic enuresis. A detailed history, thorough history examination is required, and maybe a detailed history may be required at intermittent phases also, maybe on a monthly basis. You can again go back to your history, go back to your bladder diary and see whether you have missed something or something new has come up. It's not one-time history taking, it's like a history taking on every visit. Routine ultrasound, renal function test, radiology is not required in primary monosymptomatic enuresis without red flag signs. Education, no punishment, treating of constipation and your comorbidities form the baseline. And drugs like desmopressin and alarm therapy can be given depending on the phenotype of the patient and the family. Combination therapies can be tried in case the child is non-responsive to therapy. So dry nights for good mornings is what our theme is. And engage when the child is bothered. Alarm usually cures, desmopressin controls, and a combination gives you the rescue. So coming to my last slide. So as pediatricians, as we know that there is n number of options available for managing bedwetting in the net, whether in the form of drugs, whether it's allopathic, homeopathic, or Ayurvedic. Alarm therapies are also there. Astrological remedies are also there. Massage therapies are also there. And home remedies are also there. So much is there. But if the patient has actually left all this and come to you as a pediatrician, so you are need to find out what is the reason of bedwetting in my child. Secondly, how to give them a tailor-made therapy, how to monitor them, and allay the anxiety of both the parents and the child. So this is what is holistic approach in children with bedwetting. Thank you.
Thank you, Dr. Kanav, for a wonderful session. We welcome Dr. Alok Bhandari, Treasurer Central IP, and Dr. Lalit Mehndiratta, Past President IP Delhi. Dr. Bhandari, sir, are you there? But one thing is there that we must explain to the parents that most of the time it may be physiological and it will go away with time. And because they may be insisting on medications or devices, but we must tell them it's not that just for your inconvenience, you must treat the child. Dr. Bhandari, sir, please say.
Good morning, dear friends. It was a really enlightening talk, and the way Dr. Kanav has covered the entire topic, it is really commendable. And my compliments to Dr. Neha Bhandari also for conceiving this program. And really, I'm getting a very good feedback of these Master E classes in pediatric nephrology. It is benefiting not only the youngsters, but the elder generation or the senior generation, or we can say the previous generation of pediatricians also, that awareness about different aspects of pediatric nephrology are being very nicely covered. And my best wishes and compliments to IAP Delhi, who is doing wonders under leadership of Dr. Ajay Gupta and Dr. Dinesh Goyal, that really IAP Delhi is regaining its position of academic capital of India, so far as pediatrics is concerned. So best wishes and good luck to all, dear. Thank you. Thank you.
Thank you, sir.
Thank
Thank
you.
you so much for
Thank
your
you.
kind words. It's an honor to us you have joined the session. Thank you.
So we would request
Request
Dr.
the chairpersons.
Yeah.
Can I say a few words? Yeah, it
Sure.
was as usual. It was an excellent lecture, we say, or a talk by Dr. Kanav Anand. He covered every aspect of bedwetting in children. Dr. Kanav and Dr. Girish, you being an expert, I have a couple of questions. The first being that although the literature says that about more than 7 years, about 10% of children have bedwetting, and in more than in teenagers, the bedwetting is about 1 to 3% or even more than that. What in your practice, you are experts, so probably you will have more patients because the patients are referred to you. What would be the prevalence in India, and how many of your patients would be there with bedwetting?
Yeah.
Dr.
Thank
Kanav and
you.
Dr. Girish.
Okay. So
Dr.
first of
Girish
all,
Sikandar.
yeah. First of all, thanks, Kana, for this nice talk. Always it's good hearing excellent talks from you. So regarding the first question, the prevalence, we did a study in early 2017 in central India. So the prevalence was approximately 15 to 20%. And obviously, as the medical literature suggests, it decreases with the age. And like for the teenagers, usually in our clinical practice and what the guidelines suggest, we usually start therapy if the child is 7 or more, older than 7 years. But if there are some social problems, as Kanav also highlighted, if the patient is having some socio-economic, like social issues with handling the aneurysms, we can start the therapy at an earlier stage. So some of the quite important questions were how to like go for the therapy with a desmopressin. So usually we give the therapy for a desmopressin for a 3 months total duration. But after 3 months, we don't have to stop it. We have to have a structured withdrawal. And studies have also shown like that meta-analysis was published in the pediatrics, I think, in 2018 or 2019. And they have shown that if you are decreasing the dose, only the dose, not the duration, then the chances of the relapses are lower as compared to if you are abruptly stopping the drug or you are giving the this drug alternate day. So better to reduce the dose. For example, if you are going with a 0.2 milligram, better to give it 0.1 milligram for 6 to 8 weeks and then stop. Regarding the comorbid conditions, what conditions we see, we usually have a patients with, like I just do remember, we have 3 or 4 patients in which we have done a polysomnography, and we found that 2 of these patients who were referred to as a refractory aneurysms, they have obstructive sleep apnea that is of a severe grade. So 2 of these patients, finally, these underwent adenotonsillectomy, and finally, the aneurysms resolved within a period of 4 to 6 weeks in these conditions. Yeah.
Yeah. And Dr. Neha also, and now Dr. Kanav and Dr. Neha is also a nephrologist. So are both of you, so is there any use of the newer drugs like solifenacin or trospium chloride? Have you used that? And are they of any use? Although literature says that they can be used.
So for
Dr. Kanav?
Yeah, Dr. Neha.
Yeah,
so
Dr. Neha, you can answer that.
So for anticholinergics, like for what we are using anticholinergics is small bladder capacity, right? So as Dr. Kanav said, that if you are using anticholinergics like oxybutynin, there's a lot of side effects, especially of constipation. But with solifenacin, we have an advantage that it does not cause constipation. Plus, it can also helps in a bladder if there is detrusor overactivity, which we are suspecting. So in those cases, it may help. We can use because it is available in syrup form. Oxybutynin is only available as a tablet form. But still the preferred drug is oxybutynin only as compared to solifenacin. And I think Dr. Kanav can tell better about it, sir.
So in my practice, since we treat constipation first, followed by giving the drugs like oxybutynin. So oxybutynin still forms the baseline. And usually what I add is a mirabegron that is there, which is a phosphodiesterase 3 inhibitor because that works in synergy. So in case you have used an oxybutynin and you're not getting an adequate response, mirabegron will act like in a synergy fashion. So it will increase the efficacy of the drugs. But remember one thing, since we are discussing this part, so if the child is having pure, you can say monosymptomatic enuresis, the drug of choice is like you can say the therapy of choice is still alarm therapy, not these drugs. But in case the patient is not able to comply to the alarms, not being able to use the alarms, then these drugs can be given. But if this child is having non-monosymptomatic enuresis and is having daytime overactive bladder, urgency, increased frequency, small capacity bladder, because of which you have increased voiding frequency. So in such children, definitely these drugs come as first line agent after treatment of the constipation.
And what about trospium chloride? Any word about that, Dr. Neha?
I'm not sure.
Supposed to be a bladder relaxer or something, the newer drugs. Any information regarding that?
I think we are only using
What is it?
oxybutynin and solifenacin and megaberon. That's
Okay. One last question. As a pediatrician and all those are students who are joining with us, when should a patient of bedwetting or enuresis be referred to you super experts, you nephrologist? Well, tell what level can a normal pediatrician treat? And what are the red flags, and when should a pediatrician decide, no, right now the patient has to be referred to a nephrologist?
So I think first most important thing is that whenever a bedwetting is treated, we never go for a voiding diary, which I think is the baseline. As Dr. Kanav said, that we as a pediatrician, first of all, we should always ask the parents to make a voiding diary. Fluid restriction is something that we can basically start for all the children, as sir said, like 40, 40 and 20, and treating comorbid conditions, whether it is constipation or obstructive sleep apnea or adenoids enlarged. So I think these are the basic things that any pediatricians can actually cover. Plus, if you are finding any red flag signs where you are thinking that there is some daytime enuresis is also there, or lower urinary tract symptoms are there, these are the basic things. So once as a pediatrician we have ruled out everything, we have done the basic workup, and we can even start on, like as Dr. Kanav said, that until unless you are having suspecting some lower urinary tract symptoms or daytime enuresis is there, actually a pediatrician can start all the medicines. But most of the time when we get patients, we don't see any voiding diary made. They are just started randomly on desmopressin, which is given for a period of 3 months, and abruptly it is stopped, and then the child starts bedwetting again. And that is the main problem, because then the parents say that we have already given the medicine, but he has relapsed and now still wetting the bed. So I think the most important reason for this class is that we should start with basics first. A voiding diary is a must, and every time in follow-up, we just want them to make a voiding diary for 24 hours again, so that we know how much is the improvement going on. So I always feel that as a pediatrician, we can start the treatment, but if we feel that it is a refractory, or it is not responding, or there are reasons which we cannot find out why we cannot taper off the drug, then I think it would be a good idea to refer to a pediatric nephrologist. I think sir
So I
can add.
just,
Girish
so I
sir.
just like to add
Dr.
on
Kanav.
as, yeah.
Yes.
So like as shown in my slides, that in case, in addition to what Dr. Neha has said, in case there are red flag signs, the child has had recurrent UTIs in the past. Okay, the ultrasound was showing some abnormality in the bladder or in the, you can say the kidneys. The child is not gaining weight. There's failure to thrive. The urine output is on the higher side. Okay, the child is having polyuria. So that these children require additional management other than just management of bedwetting. So these are the children who actually need a referral so that you can give them an adequate therapy. Because unless those comorbidities and other issues are managed, bedwetting will never get managed. So and plus, as what Neha told was that in case the child is refractory to treatment as per what the pediatrician has done, then definitely they need a second opinion in terms of what more can be offered. But in case of red flag sign, definitely they need the early referral. Because we have a couple of patients who are being referred, who have actually you can say they have come in for maybe kidney failure, a chronic kidney disease, and for kidney transplant and dialysis. So if you ask them in the past, so they say that in the past, this we had bedwetting. I went to my pediatrician. Either he did not say anything, or he said just with time the child is going to grow up and is going to get better, or drugs like desmopressin was given for which no response was there. But then the child was never evaluated whether there is polyuria or not. Maybe he's having, you can say, the concentrating ability of the kidney is not there because of the early phases of the kidney dysfunction. So these are the children who actually get missed off. So hence, blood pressure monitoring, the growth monitoring, response to treatment, and the you can say because in the early phases when the GFR is not fallen less than 50%, that definitely the creatinine continues to be normal. So these are the kids who actually get missed off, and then in retrospect, when you see, okay, the child is actually gone to show bedwetting, but nothing was done for that.
Dr. Neha, good morning. Can I ask one thing?
Yes, sir.
Good morning and very nice session,
Sorry,
Dr.
sir.
Kanav. And
Thank you.
very nice as always. Two things are this mobile addiction and social media usage on computer and laptops, is it related to enuresis? And how is your experience of alarms over desmopressing? How do you find alarms being so compliant? What is the compliance and the success rate?
So first of all, talking about the social media usage, so we find these children who have lot of seeing mobile or they are on using social media, there's a lot of problems of holding of urine, which you really find them. So these children may actually have, a lot of times mother will come that the child has, we find the undergarments are wet, or the child just rushes to go and pass urine. Sometimes they actually come with a problem of overactive bladder, but when you actually take a voiding diary, you will find that this is a very lazy bladder because they don't want to go and pee. So they are actually wetting their pants, or they are just running to the washroom. So urgency can be there. So these are the problems that are more common. If I talk about, yes, nighttime bedwetting, like sir said, that secondary enuresis. So a lot of these children are seeing some scary stuff in the phone, because of which they may actually start having secondary enuresis, which is very common. So actually social media does lot of impact on bedwetting, I would really say, because they have sleep issues, which is again one of very important causes for
Yes.
us. Definitely we tell them to have a bedtime routine, which is again one of the urotherapy that we are using,
Yes.
that they should go off to bed by 10 a.m. We should need to switch off the lights and stop making them
So
sleep.
medications will not help in that case, right?
Yes, so it is very important. Then talking about bedwetting alarm, as I said, this is the primary modality of treatment, but then there are a couple of issues with bedwetting alarm. The success rate is high if it is used properly, because what happens mostly, if the electrodes are not placed properly, so what we as parent want is that first drop of urine it should start buzzing, but if you have not kept the bedwetting alarm properly, it will not give an alarm. Plus most of the time you will find these alarms are little softer, they are not very loud. So initially we tell the parents, that is how we counsel, that initially the parents will start getting up and eventually the child will start getting up. But the placement of the electrode is also very very important. Once the child becomes treated, then you really find that they become all right. I mean, if they are dry for 14 days, they will actually be dry.
And
So
how long you continue then? What is the criteria now we should stop the alarm?
So now they say that if for 14 days the child is dry, then you should stop the alarm. But usually we counsel them for 3 months at least. Minimum period 3 to 6 months before they become dry.
Thank you.
I
Thank you.
think
So
so.
basically, it's 3 to 6 3 months. You have to tell them it may take for the response to come in. So they should not anticipate that within a week or 10 days the things are going to get better. Two is 14 consecutive dry nights is when you can stop using the alarms. Because alarms is just like you can say a backup which has been
Yes.
there.
Right.
So
Yes.
14 days there's no bedwetting, you can just stop it off.
Thank you.
Mhm.
Thank you.
Yeah.
So Dr. Girish, one question more. What are the side effects of desmopressin we should look at? What a
Yeah.
pediatrician should look at?
Yeah, it's a good one. So, what the studies have shown that if the dose of the desmopressin here is quite low, so the chances of hyponatremia, which is a common side effect, is low, especially when you are using it for a anuresis. So, one should not worry about the hyponatremia, and these patients should not be tested regularly for hyponatremia. But yes, if the patient is febrile, if the patient is having diarrhea or dehydration, in such cases, this drug should be stored for this period, and one should be particularly he should request the patient that if these patients is having these conditions, the drug should be stopped, and one should not take more than 200 ml of the water after the desmopressin has been taken, especially because the chances of hyponatremia are high. So hyponatremia is one of the most common side effect of the desmopressin, which should be looked for.
And it is usually more common when you use the spray formulation
Yeah,
because there
that is
how
not
much will
recommended.
not
Yeah.
recommend.
So it
And how
was
much the
You
child
already
initially
is going
said
to
it's
take
not,
also, no?
which you
initially, yeah.
already said is not recommended
Not
Not
nowadays.
recommended, not recommended. Most of the pediatrician nowadays, like some they use, but like the post-marketing survey have shown that they should not be used because of the chances of the hyponatremia, because of the erratic absorption of this nasal form.
And what is the time at which desmopressin should be given? Should be given early morning or in
Okay,
at
yeah,
night
this is
time?
a
Would it
good
make a
question.
difference?
Yeah. So it should be given just 1.5 hours before the sleep. Okay. 1.5 hours before the child goes to the sleep, and before that the fluid should be restricted. During the evening only 20% of the total fluid should be given, and this should be continued. Like if the child is responding to 0.2 milligram, just continue 0.2 milligram for 3 months, and then taper off for next 6 to 8 weeks and then stop. If the child is not responding, look for like initial 14 days or 21 days, and if not responding, you can increase the dose by 0.2, 0.4.
I
I
hand
think
over
there is no more
to
questions.
Dr. Neha Bandari for the closing statement because so already over the time.
Sir, I think we will
Yes,
hand
yes.
over to, yes, we will hand over to Dr. Dinesh sir and Dr. Ajay sir
Okay.
and Dr. Ravinder. I don't know if he has joined with us,
Yeah, he is
I
there.
think he is not joined.
I saw his name in
Uh,
the participants. He was there.
but we would like to thank everyone for this wonderful session, especially Dr. Kanav sir. As
Thank you.
always, excellent session. We all are,
yes, yes,
I think everything is very, very clear. Thank you so
yes,
much.
yes,
And Girish sir and Piyush sir for, like, all of you have done a wonderful session. Thank you. We
yes.
are getting
Great, great.
response.
So, thank you so much from IIP Delhi office to our esteemed speaker of today, Dr. Kanav sir. Really,
Thank you.
really very knowledgeable session of bedwetting today. And our expert, Dr. Grish Bhatt, thanks for sparing Sunday morning time. सर ये हम हर संडे करते हैं हमारे लिए तो हर संडे है
Yeah.
एंड Dr. Piyush Jain sir, our lovely, our member and lovely person as a person
Thank
and
you.
great human being. And thank you so much, sir. Sunday morning में आपने join किया and knowledge को थोड़ा सा spread किया. And with this, thanks to the all delegates and all faculty and everyone. And in the end, none other than our superstar, Dr. Neha Bhandari. Thank you so much. Thank you so much. Good
Thank
day.
you very much.
Thank you.
Thank you.
Thank you all.